Joining us now is Dr. Mark Verdun, who is the orthopedic surgeon at ACMC. Mark, welcome.
Thank you.
Is it snowing?
A little bit.
Was it really? I'm getting all kinds of reports that it's fallen towards the lake.
Yeah, I came in on the lake. It was coming down. It's more ice than snow.
Oh, really?
Yeah.
No, I'm expecting to have maybe an inch of snow today. It's been a while since we've had you on, Doctor, and we thought we'd ask you some questions about orthopedic surgery and that sort of thing. Now, we're getting a phone call. I don't know what this could be, how it could possibly be regarding this segment, but I'll take it anyway. Hi, you're on the air.
Yeah, I'm sorry to bother you, Pat, but we're getting snow over here in North Carolina.
Pretty good?
It's hitting the rooftops.
Okay, it's that time of year.
So.
Yeah, I appreciate it, Dorothy. Thank you.
And I didn't mean to interrupt you, but
that's okay. That's all right.
What I wanted to
Bye-bye.
tell you.
All right, so we're getting more reports that the snow is flying. It's that time of year, I guess. Mark, tell us a little bit, before we get into any other major questions here or anything about this particular subject, tell us a little bit about your background and yourself.
I've been practicing at ACMC for about the last 2.5 years. I came prior to that from South Dakota in a private practice there.
Really?
Yeah, and I trained here in Cleveland at one of the Cleveland Clinic affiliates at South Point Hospital. Before I was a physician, I was a research scientist. My interest was in human performance, primarily fatigue.
Really?
You know, what it took to have somebody collapse, essentially, no longer be able to perform work. Did work with U.S. rowing, U.S. cycling, more physiological testing type stuff than medicine. That was all part of the research. I was originally from Illinois, moved out here to go to school and haven't left since.
How did you get to South Dakota?
I was met someone at a meeting and went out there to practice for a few years. I really liked it out there.
I was going to say that would be pretty good country to be in.
Oh, beautiful country.
Yeah,
beautiful country.
So you've been in this area about 2.5.
2.5 years.
2.5 years. Does the weather bother you at all here?
No, I grew up on the lake in Illinois.
Yeah, right.
So I'm used to this, and South Dakota is much more harsh than this.
Yeah. Now I understand that you're quite a is it a bicyclist?
Yeah, I ride quite a bit.
Do you really?
Yes. If I continue my current pace for the winter, I'll eclipse 350,000 for my life, or at least since I've been keeping track.
Is that 350,000 miles?
Yeah.
Nope.
That's kind of a obsession, I guess, maybe not.
So do you ride every day?
Most days. I ride to and from work most days.
Do you really?
Yeah.
How far is that trip?
Oh no, it's only maybe round trip about 7-8 miles, depending on if I go by.
It'd kill me. So that's amazing. What in the wintertime that you can't ride in?
Yeah, I ride. I have couple bikes that are specifically designed to ride in the winter. One has very big tires that run at real low pressures. They were originally designed for riding bicycles in Alaska.
Really?
In the wintertime, and then
I find that amazing.
Yeah. The cold weather, if you dress right, it's not.
It doesn't bother you.
No. They have stuff nowadays that keeps you warm.
That's got to be good for your health to be able to ride that much. You know.
That's why I do it.
Good for you. Orthopedic surgery. What's one of the most common surgeries that you have to do?
Probably the most common thing I think any orthopedic surgeon does is a knee arthroscopy, operating on the knee with through small portals, through small incisions. To clean up the meniscus or treat arthritis, sometimes reconstruct ACLs, those kinds of things. But the knee, by far, arthroscopy is the most common.
You hear a lot of knee situations, especially as you get older.
Right.
And probably with athletes too.
Yeah, that's one of my interests, is the aged athlete. As you know, I was quite active and beat myself up, but now I kind of pay for it, and so that's kind of an interest of mine, that people that as we get older and still want to participate in activities, what can we do to help them continue to participate from an orthopedic standpoint, but not only that, but from a conditioning standpoint.
I remember playing from Little League on up into even men's slow pitch softball as I got older, and I quit around 30 years of age, and then in 20 years time, it seems over that 20 years time, the knees have suddenly gone. I mean, it's like the running and the jolts that I took back then.
Yeah, some of that is, I think once you stop the strength around the knees and the hips and the things that are important to kind of taking up the pounding of everyday life, they kind of get weak. And so we beat them up when we were younger, kind of lay off for a little bit. And as we get weaker as we age, then I think some of that has to do with the pain we have down the road.
Do you find that, you know, people that might have this problem with the knees that, I'll tell you, and let me just give you an example. I was having some sciatic problems and some problems with the knee here last spring. And so I was doing some garden work and, you know, bending over and everything, and it was hurting a little bit. But you know what? The next day or two, it actually felt better because it seemed like it was because I was working things out or something instead of sitting on my butt. And
absolutely.
Does that work?
Yeah, I see that. See that a lot. Where I'll have a patient that'll come to me and knee problem, back problem, and one of the mainstays of my practice is to put them in physical therapy, and they'll come back to me and say, this hurts too much, I can't continue. I said, just be patient, go slow, it's a marathon, not a sprint, it'll work out for you. And you know, if they can continue to do that, I see that the actual physical movement really helps. It doesn't, I don't think it doesn't matter if it's the knee, the shoulder, the ankle. If you can get someone to do it and they do it under controlled situations where they're having some education from a therapist or their physician on how to do it, I think that it can be extremely beneficial.
Wow. So you do the actual surgeries yourself?
Yes, I do the surgeries.
Can you do it there, or do you have to go to the clinic?
No, I do it here. I do anything from joint replacement of the hip and knee and the shoulder to shoulder arthroscopy, rotator cuff repairs, to fracture management. ACL reconstruction in the knee, other ligament reconstruction in the knee, foot and ankle surgeries.
Really?
Yeah. What I do is things that I see a lot of in my practice that I can stay good at, I guess, is if you don't see enough volume, you don't stay good at certain things. And so some of those surgeries, without the repetitive nature of what surgery is like, it's just something that's better sent to someone that does it all the time.
The success rate of these kind of surgeries probably depends on the patient itself.
Yeah, a lot.
The rehab.
Yeah. For example, the arthroscopy we were talking about, the knee. There are a lot of people I see that have 2 problems in the knee or 3 problems in the knee. That one is treatable with the arthroscopy, the other is treatable with other types of surgery, joint replacement. So once you get to about 40 or something, I start to see the arthritis start to creep in more and more. And that's not really treatable predictably with an arthroscopy. If you have a meniscal tear, a floating cartilage tear, that is. And so I have a long discussion with my patient. Look, you got 2 problems here, and some things we can treat, some things we can't. The simple thing is to do it on arthroscopy and try to treat it that way. And if it won't work, then there's some things we can try.
If it is arthritic, then there's really not a whole bunch?
Depends on, there are some things that can be done. There are some injection type therapies now that either from cortisone injections, which used without discretion can be harmful to the joint, more so the soft tissues of the joint. And then there's something called viscosupplementation. It's hyaluronic acid. Some people call it coxicone. But that's lubrication is kind of a real lay way to say this, but it's a chemical that's produced by some of the cells in the cartilage, and it's designed to kind of lubricate and things like that in the joint. But if you have focal defects, like the younger kids that come in their 30s and they have just one area, terrible arthritis, I do things like harvest cartilage from their knee, send it off to a lab, have them grow that, bring them back 6 weeks later, and reimplant it. I take bone plugs either from cadavers or from healthy parts of the knee that are non-weight bearing and switch those around so that the bad cartilage goes to where there's no weight bearing, the good cartilage goes where there's weight bearing, to try to treat those things.
There's been so many changes in technology over the years. I mean, you've probably seen it in your short career, probably.
Oh, absolutely, yeah.
My mom has a situation where she has the pain. She's elderly, and she said it goes down her leg, and I think she has a herniated disc, and they give her shots. Sometimes it helps, sometimes it doesn't. She's in a constant pain with it. She gets very annoying, But they gave her a drug called It's supposed to relieve the pain.
Morphine?
No, Morag or Mora, I can't remember, MR something. But at any rate, as it turns out, it worked for like a couple of weeks, and then she goes, no, it doesn't work at all. She goes, so she doesn't understand that situation. But they more or less, I think what they more or less said is you got to live with this situation. Is that the way you have to go nowadays?
There are sometimes there's always something that can be done. Is it the best thing to do? Not always. I have patients that will come to me and have the same kind of problem that your mom's having, and I'll say, look, these are the options. What would I do? You know, I'm not sure I'd let someone operate on my back because these reasons. You know, my health isn't there. I'm not sure how much benefit you're going to get from it. Those kinds of things. Or look, you're miserable. Maybe it's something you should try. You're having progressive neurological deficits, meaning your leg's not, you're getting weaker and weaker and weaker in your leg. There are certain reasons to have surgery, but there are other reasons that are kind of, you know, personal. You got to make that decision on your own.
My dad had, when he was alive, had back problems, and he always said, if you can avoid the surgery, avoid it. Yes. You know, but then you don't want to be relying on Demerol and everything else.
Right. Correct.
You know what I mean? Let's take this call, Mark.
Sure.
Hi, you're on the air.
Good morning.
Hi.
I have spinal stenosis, and I was wondering, I do not want surgery. I don't want the steroids or those injections. What would my next alternative be?
There'd really only be one alternative kind of left, or two kind of. One is medication, so it takes a medication that would help you deal with the pain. And number two is physical therapy. Spinal stenosis is kind of a hard problem to treat other than through surgery and injections, because essentially it's like a corroded pipe, and the only way to correct a corroded pipe is to clean it out. And so that's where the surgery comes in, and the injections are tried to help reduce the inflammation in the soft tissues surrounding the area where you have stenosis.
Yeah, I've tried the injections before. They didn't last, and the steroids made me a nasty person. I did not handle them well.
Yeah, we call that steroid psychosis. That's a known phenomenon with taking corticosteroids, either by mouth or injections. It's usually more common with taking it by mouth than it is from injections, but
I've tried it both ways, and yeah, it don't agree with me.
Yeah.
It makes you mean?
Yep.
Nope.
Very agitated. Yep, I get aggravated real easy.
Wow.
My brother's the same way.
I'll be darned.
Yeah.
Sometimes if you have surgery to try to correct this problem, they call it a decompression or a laminectomy or laminotomy, you can become unstable. So if you ever got to the point you would consider that, I'd have that discussion with your spine surgeon, because sometimes they go in there and try to decompress.
I don't want surgery.
Yeah, I don't blame you.
Okay.
All right. Is there any certain medication that I take naproxen, but I've taken it so long that it doesn't seem to have much oomph anymore.
Do you try Tylenol, or do you have problems with your...
I take Tylenol along with it every day.
There are a couple medications. One is called Neurontin and the other is called Lyrica. I usually don't use those very much in my practice, but they're nerve stabilizers to treat nerve pain.
Yeah.
And I don't know if you've tried those, but usually pain management doctors and neurologists use those to kind of help with the radicular type, the pain going down your leg.
Numb. Yeah.
Yes, that may help with that. They may be able to give you some relief. So if you have a neurologist or a pain management doctor, you may want to ask them about Neurontin or Lyrica.
Yeah, I went down to D-Day and was trying to walk around taking pictures, and I went to 2 benches, and by the time I got to the 3rd bench, I fell in the flowers, and I think people thought I was indulging in the bubbly, and here it was, I just lost the feeling of my feet and went down.
Yeah.
So, yeah, it's hard to live with.
Sure, I understand.
All right, thank you very much.
Thank you for your comments.
Bye-bye.
Bye-bye. Aleve, people have asked me about Aleve. Does that have aspirin in it?
No, Aleve is naproxen. It is a non-steroidal anti-inflammatory medication, but no aspirin.
Would that something work for what she's?
It may, on the spectrum of strength of anti-inflammatory, it's pretty low.
Is it?
Yeah. The problem that usually occurs with spinal stenosis is an anatomy change, just like a corroded pipe in your house. So it's not necessarily an inflammatory response. The bones have thickened, and when they thicken, they close down the space for the nerves. And so the real way to take care of that is surgical. But then sometimes when they do surgery to take the bone spurs out, then the spine becomes unstable. Then they have to fuse. So so it's just a tricky situation.
I know. I was put on a steroid type thing for, I think, the knee pain. Mm-hmm. And you take 5 one day, go to 4, 3, 2, 1, like 4 days or something.
Yes.
Doc, I was running like I hadn't run. My wife said, "I've never seen you run in 30 years like this," and she also said, "You should be on those things all the time because your personality is much better." Well, it's because I wasn't in the pain, I think.
Right. Oh, absolutely.
It changed my attitude, so it didn't affect me like it did her.
Yes, there's two. We call it steroid psychosis, but there are euphoric states where you become very happy and
I was very happy.
Lots of energy, don't need sleep. So those are things when you get on these medications that can happen.
And that's why you got to get off them.
That's right, and they're bad for everything.
Yeah.
If you take them too long.
Hi, you're on the air.
Hi.
Hi.
Does inversion help stenosis?
Yes, it can. The tricky part about inversion is that essentially when you stand up, the blood pressure is higher in your feet than it is in your head. Does that make sense? And when you invert yourself, the blood pressure now becomes higher in your head than it does in your feet.
Right.
If you have a weak blood vessel in your head, you can have a stroke. And so inversion has been used. It's just like spinal decompression that they use in the therapist's office. But when you do inversion, you have to worry about having a problem with the blood vessel in your head and that bursting. So I don't usually make those recommendations without knowing a full medical history.
Mm-hmm. How about slow and not long? I know some people turn totally upside down and just kind of hang there, but if it's slow and maybe a 60-degree, would that be dangerous? Or
it could be. Highly unlikely, but it could be dangerous. It all depends on if you have a weak blood vessel in your brain or not.
Okay.
And that's not something you can necessarily pick up. You can go to the doctor and they can test for.
Okay.
All right.
What would you ask for if they were on test?
If I wanted to know that, you'd probably need something called an MR arthrogram of the head or of the brain. So they inject dye into the blood vessels and then take an MRI of the brain both before and afterwards and to look to see if there's any dilation or widening of the blood vessels where the wall may be weak.
I see. Okay, thank you.
Good comments. Thank you.
Bye.
Bye-bye. Well, I've got 2 emails for you, Doc. They want to know if 2 women want to know if you're married. I asked the guy did. I really did. I got them off there because their names were. They're interested.
No.
No, he's not. There you go, girls. That's the first for us here in the show. Hi, you're on the air.
Yeah, I don't know if you can answer this question or maybe it's a goofy one. But anyhow, a bunch of us were sitting around talking last night and we're getting older and we're getting leg cramps a lot. And is there something you can do, especially while you're sleeping and you got to jump out of bed and walk?
That's a hard question because we really don't know what leg cramps are. There's been a lot of research in trying to figure that out. It can be anywhere from too much caffeine intake, too much soda intake with the phosphorus, the brown sodas. It can be from electrolyte disturbances, meaning the salts in your body aren't properly aligned. You're dehydrated. You can have something called restless leg syndrome. So there are a lot of reasons to have these cramps. The real question is, what is the cause of yours? And you kind of have to take a step back and look at, am I eating right? Am I drinking too much coffee? Am I drinking too much tea, too much diet soda and those kinds of things, and try to work back from there.
So just kind of maybe cut one thing out at a time to
Correct,
see
yeah.
what happens?
Yep. Or reduce it. I'm not advocating getting rid of your coffee or your tea, but just instead of drinking 6 cups, I don't know how much you drink 2 cups a day.
Okay.
Okay.
We'll try that.
Okay, good luck.
Thank you. Bye-bye.
Bye-bye. Talking to Dr. Mark Verdun. If you'd like to talk to him, he'll be here for a few more minutes. 593-7181. If you'd like to give him a call, a lot of phone calls this morning for him, and emails. Good morning, you're on the air.
Yeah, those leg cramps that lady was talking about. I get little blood sugars every now and then at night. I've been a diabetic for 27 years, and I take insulin every day. Could the low blood sugars cause my legs to cramp up at night?
I don't know of any direct evidence of that, but I'm not a endocrinologist that would study that all the time. But there are times where when you are low in sugar, the ability for your muscle to metabolize is different, and you have to rely on metabolic fuel from inside the muscle that can be depleted quite quickly. That can cause, it's called tetany or cramping. So that I don't know about in the resting state. Most of what I know about with regards to that kind of thing is in someone working over long periods of time, doing exercise or walking or that kind of thing. So to tell you 100%, I don't know. Sorry about that.
Okay, thanks.
Okay.
Thank you. I think I self-diagnosed myself on something. I was reading a column the other day. I read the doctor's columns and that, and they were talking about something called trigger finger.
Okay.
I have that, I think, where the finger locks.
Correct. Yeah.
And I don't know what is that arthritic?
It's part of something called the arthritic hand syndrome, which is arthritis, cysts, ganglion cysts, trigger finger, and carpal tunnel. So as we age, our hand starts developing. What trigger finger is, the flexor tendons, or the tendons on the palm side of your hand, there's a lubrication sheath around that, and they run in a pulley system, and so when you bend your finger, the tendon doesn't pop off the bone. It gives you more mechanical advantage.
Yeah.
And as it inflames and gets thickened, it comes down to the knot that you get in the tendon, comes past the edge of the A1, something called the A1 pulley, the last pulley, and as you try to extend it, that knot gets caught on the edge of that pulley, and you can't take it straight
Is there
down.
anything you can do?
Yeah, usually the treatment for those, usually I start with anti-inflammatory medications and corticosteroid injections to reduce the inflammation. I really think that when you come to me, if it's been 3 weeks, 4 weeks, in the acute phase, or it's not been there a long time, it can be treated pretty effectively with that kind of thing. Someone comes in and tell me this has been going on for 6 months, the changes now in the tendon are chronic, the type of inflammation is different, and its ability to respond to anti-inflammatories, either non-steroidal or steroidal anti-inflammatory medications, are much more difficult. And then that's a surgical procedure, which is you just release that pulley so it can't get caught anymore.
Oh, I see.
Yeah.
I see.
And it's very, quick surgery. Recovery time's probably 2 or 3 weeks until the incision heals. There's nothing from the surgical standpoint to heal other than the incision.
Yeah. I'm surprised I don't have carpal tunnel, because I've typed for 40 years, I only type with these 2 fingers, that being one of them. But a lot of people have that carpal tunnel thing, and I'm fortunate that I don't have that from all the typing that I've done. We're getting a lot of calls here. Hi, you're on the air.
Yeah, would you recommend osteophyte for people that have joint pain?
What I know about that medication is that they did a couple of studies. The last one was in 2009. And what we know about that medication, it helps half the people, and it doesn't help the other half. What they also know is that over the long term, and up to that point it was 17 years, they haven't found any detrimental effects of that medication. So what I tell my patients is, as long as you're not changing anything else, I mean you're not starting therapy, having surgery, try it for 2 months. If it doesn't give you relief by then, if you don't waste your money, because it's not cheap to buy. So,
I know it's not cheap, it's expensive, but I would just wonder, because sometimes I have joint pain right here where my foot and my ankle bone comes together, and it hurts terribly, and I was just wondering if I should take it.
I think if it's not a financial burden, then I think it would be worth trying for 2 months. And I don't think that OsteoBioflex, the more expensive one, is any different than the one you buy at Walmart or any place. The generic are just as good as.
So in other words, what you're trying to say, the generic is as good as the osteophyte one?
Yes.
Oh, okay.
All right.
All right, thank you.
Okay, good luck.
Is that stuff you put on for heat?
No, that's BioFreeze. This is glucosamine and chondroitin.
Oh, yeah.
Joint supplements.
Yeah.
And they take them by mouth. It's highly variable. I take them personally, but I benefit.
You do take it?
Yeah.
Because I had a former quarterback for Ohio State. He's older now,
Yeah.
but he back in the '60s, and he told me that he takes that and it helps his joint pain.
Yeah, it helps mine too.
Does it really?
Yeah.
I probably should do that. This from Lois. Years ago, traction was often used for back and neck pain. Why is it no longer used?
I think it still is. It may be underutilized. I have neck problems. I have home cervical traction units.
Really?
That I use.
My dad was on traction a lot.
They still use it. At least some people are still using it in the therapy program for both the lumbar spine, the traction tables, and
that pulls it.
Yeah, to decompress the spine. So I think it's still used. I think in the advent of the advancements of spinal surgery, just like anything else, they go to the things they think are going to help the most. But surgery is not necessarily the answer all the time. And if you're having problems and you are with a therapist or go to your physician, just mention that, what do you think about this? And I think that the therapist for sure can implement that.
You mentioned, Mark, about fusing. I had a boss that had his back fused, and he had to move like this.
Yeah.
His neck was apparently affected. What did that do for him? Did that take away pain?
That was the goal of the surgery, was to...
And we're talking 30, 40 years ago.
Right, correct. Yeah, the goal was to the joints are, because they're degenerated, they hurt when they move, when they degenerate. So the goal is a couple things. The space between the bones closes down, and that causes pressure on the nerve. And so what you do is you jack that height back up to take the pressure off the nerve, and then you fuse it so there's no motion. It becomes one solid piece.
Okay.
So that's the goal behind the surgery.
Wow, you went through a workout today. You had a lot of phone calls and emails, and very interesting segment here, Mark. I appreciate you coming in. And if I don't see you, have a good Thanksgiving coming up.
You too.
Thank you.